All right, Jen, whenever you're ready.
Okay. Well, thanks, Dr. Giordano. This, I often feel that my patients are confusing, but this lady is particularly has a lot of different things going on. So she is a 70-year-old Caucasian female who has type 2 diabetes, and that's what I'm asking about today.
Okay.
She has an elevated BMI, 31.7. She has hypertension, but it's currently really well controlled, as you can see from the vitals there. Many years ago, she had labile hypertension, but she's done really well in the past 5 years or so. Pulse is 62. She had a recent fundoscopic exam by our local optometrist that showed no diabetic retinopathy. You can see some of her immunization status there. She has not had her flu shot yet, but she's good about getting that. I think she's behind on dental exam, and I did not do sexual dysfunction screening with her. Her most recent A1C was 10.5, and just to say a little bit more about that, her control over the years has been really variable. I don't think her A1C has ever been below 8. It's probably been as high as 12. For a long time, it varied. For a long time, her diet and exercise varied, and it seemed to worsen when she wasn't doing all of her diet. But I'll get to more of that later when I just get down to the questions. You can see that she does have hyperlipidemia, and that's well controlled. She doesn't have any elevation of her liver function tests. She has a little bit of chronic renal failure. Her creatinine most recently was 1.1, and her GFR is 49. I don't think she has hypothyroidism. I can't remember. She might actually. Normal potassium. So just to talk a little bit more about her, let me get my note here. So my question with her is there anything else I can do with her medications? And as I was filling out the echo form, I realized a couple of things myself, as I often do. But she is currently taking Levemir 50 units BID. I think that she might be on Levemir because of her insurance, as opposed to a once-a-day, long-acting. Her insurance is Medicare, Medicaid. She also takes Novolog on a sliding scale prior to her meals, and I did ask her if she's missing any doses. She comes with her daughter, who is supportive. She denies missing any doses. She takes her Novolog 15 minutes before she eats. So then I do have some old A1Cs listed here. Let's see, a year ago it was 8.8. September and 2019, 8.8 a year ago, and I guess that's June was 9.5. Oh no, in December of 2017 it was 9.5. So, or maybe it was 12.2. Sorry, in December of 2017. So then it came down in 2018, and now it's crept back up again. But again, never below 8.8. I had stopped her metformin at one point because her creatinine was up, but I looked back through the chart, her creatinine has never been above 1.3. So one question I have today is about just trying to restart the metformin and monitor her kidney function. She started Tradjenta in 2019. I'm not sure when I filled this out why I said I'm thinking about starting a once-a-day long-acting. I don't know what I was referring to there. I wondered about a GLP-1 agonist, but her A1C seems a little bit high to start that. I wanted your input on that, if I could try that. She does have coronary artery disease, atrial fibrillation. I could get into her chart and look at other diagnoses. She has depression that I believe is currently well controlled. Her initial A1Cs when she was first diagnosed were a little bit lower than they are now. She's been diabetic for over 15 She has a tricky economic / social situation. She lives with her adult daughter who does not work, 2 teenage grandchildren, and her adult son sometimes live with them. They don't. They have very limited resources. They often try to supplement their income by having a little flea market garage sale in their yard. They have a lot of trouble with transportation.
Okay.
And then let's just see. She has past medical history here. So she's been on insulin for more than 10 years. She does have a family history of coronary artery disease, but she herself has it. She has a nephropathy that she doesn't complain too much about. I don't have her on any medication for that. Depression is well controlled. I think I might have her on Zoloft currently. We're looking to get to her meds, hyperlipidemia, hypertension, hypothyroidism, metabolic syndrome, obesity.
Can I just clarify one?
Pardon?
Can I just clarify one thing? You said neuropathy, but she doesn't complain about that. She has neuropathy? Does she also have peripheral neuropathy?
Oh, I was misreading my notes. That's nephropathy. Yeah, I'll look in her chart. I misspoke. I don't think she has neuropathy. You're right.
No, like ulcers.
Yeah, because I was like, why does that say neuropathy? I'm reading too quickly.
I just wanted to clarify it. Thank you.
Yes, thank you for catching that. She was hospitalized in 2009 for CHF, and at that time her ejection fraction, if I recall, it was really low, and she's done quite well since then with her cardiac function. Her most recent echo was in August, and she had a normal ejection fraction, but some atrial dilation.
Okay.
She had cardiac stents in 2011. As I mentioned, she had frequent ER visits for her hypertension in the early 2000s, but that's been really well controlled for quite a while.
Okay.
No hospitalization for her diabetes. Her most recent PHQ-2, 1 out of 6. I don't know why I didn't go to PHQ-9, but possibly because I've just known her so long that she just sort of floats along at this kind of low-grade depression that doesn't get much worse and seems to have been pretty stable for a while. Let's see. She does not use continuous glucose monitoring. I think I put there that she checks her sugar once a day, but I think she checks it before meals because she's doing a sliding scale based on sugar. So she must check it more than once a day. Sorry, I don't have good details on that. There are her other medications. You can see she's taking a statin, carvedilol. The clonidine was necessary for her blood pressure. Eliquis because of the AFib. So Celexa is what I currently have her on for her depression. And then you can just, I don't need to read through each of these medications. They're pretty self-explanatory. I don't really see anything that's a surprise there. The sucralfate, I can't remember the story behind that. To my knowledge, she hasn't had ulcer, but I'm blanking on why she's on that sucralfate. And then Caitlin, is there anything else below those meds?
Nope, that's it.
At the bottom. That's it. So that's the story. I think that currently she's actually doing fairly well with her dietary efforts, and I didn't, unlike a lot of patients I work with, I didn't find anything there that I could just say that I could work with her on. As far as diet goes, exercise is less, probably only intermittent. So anyway, pretty much the questions that I stated earlier is just what I was curious about feedback on, and then obviously anything else that stands out to you.
Perfect. Thank you so much, Jen. That was wonderful. Does anybody of the participants have any thoughts, questions? All right, then I will defer to the Endocrine Hub.
So the first thing that I try to think of is, you know, if her A1C is currently 10.5 and she's a 70-year-old female, I try to think of what my goal A1C is in every single patient. She has a lot of comorbidities and she's 70. So our target is around 7.5 to 8. Also, she has an extreme history of cardiovascular disease, AFib, heart failure, coronary artery disease. And so then I try to think of how we can optimize our regimen to prevent cardiovascular disease in the future. I had a few questions about the things that you presented too, Jen, to just kind of clarify her regimen now before we talk about some medicines that may help from a cardiovascular standpoint. But you said she's taking her insulin. Is it 15 to 20 minutes before she eats her meals? Her
Novolog, yeah.
Yeah, so I would recommend taking it within 5 minutes of the meal.
Okay.
So how many units does she take? You mentioned a slide scale, but what are the details of that? Like, does she have 1 unit for a set amount of carbs, or does she just eyeball? Is it a small, medium, or large meal? How is she?
No, she's using, she is not doing it based on carbs or based on her food. She's doing it based on what her pre-meal sugar reading is. And I don't have it right in front of me, but it's a kind of our standard sliding scale for what the pre-meal blood sugar is, then adding it. So she's really not covering for her carbs at her meals. And I'm not sure that she would have the capacity to do that.
Because it sounds like she's on a pretty large dose of basal insulin.
Yeah.
And I think where we're falling short is probably her pre-meal insulin and just not getting, like you said, good coverage for the amount of sugar in her meals. And so instead of leaving it to her to do a sliding scale, I would schedule a dose of insulin. And if you're worried about lows, you can start, you know, if she's been doing 10 units, or start with 5 units, you know, with breakfast, lunch, and dinner, and see how she does with it, as opposed to a sliding scale.
Okay.
I think checking her sugars is really going to be important when she's doing 4 shots or more of insulin a day. I do think that she needs insulin because her A1C is 10.5.
I would ask her, is she missing any doses? And if she's injecting in the same spot every time, there can be some scar tissue there. If she's kind of moving around her abdomen or arms or wherever she's injecting.
Okay, that's helpful. I didn't ask her about using the same injection site. I did ask her about missing doses, and both she and her daughter, they said, no, I don't, you know, she doesn't miss doses. So that's helpful. And going to a standard pre-meal and taking it 5 minutes before, those would be different things that I could try with her.
And then I think working towards reducing the amount of insulin overall in the long run is a good plan. You mentioned restarting metformin. So her most recent, you said, was 49.
Yeah.
So then she would just do half of the dose. So if your GFR is less than 30, we don't recommend using metformin at all. But if it's 30 to 45, then you can use half the dose. And also caution in initiating it, but you said she had been on it. So I would just do 1,000 a day of metformin. And I think that would be a good start for her to try to, you know, wean the amount of insulin overall. And then you mentioned also a GLP-1 agonist. I think that'd be great in the future because her A1C is uncontrolled, and the SGLT2 inhibitor class is great for heart failure, but it's just going to make her go to the bathroom all the time because her sugars are uncontrolled right now. So I wouldn't venture with that right now. But down the line, after metformin introduction, a GLP-1 would be great. I think that's a good idea to do metformin and then a GLP-1.
Okay, good.
I
would also add, if she's still on Tragenta, if you're gonna add the GLP-1, there's enough of an overlap with Tragenta and the GLP-1 class that the Tragenta probably won't be doing anything. So I would stop that pill. The
Okay, good.
injections are stronger than the Tragenta and they work better.
Okay, great.
And the DPP4 class, which is Tragenta, they don't have protective cardiovascular like risk reduction like the GLPs do and the SGLT2s.
So that'd be a better choice for her to get the GLP-1 agonist instead of the, okay.
When you're
That's
comparing
helpful.
GLP-1 versus DPP4, yes.
Good, okay, good. Okay, well, those are helpful suggestions. Thank you all.
Thanks for always sharing, Jen. We appreciate it. Caitlin?
I was talking, I was muted, yeah. Sorry, everybody. So does anybody have any questions about this case or anything that came up? No? All right, if you guys think of anything, you're welcome to use the chat feature, and you're also welcome to email me, and I'll make sure that it gets passed around. But we will move on to the didactic. And Jen, do you care, Jen Giordano, excuse me, do you care if I share your screen, my screen for you?
Go ahead.
Great. Can you guys see this okay? Or should I take it back to the way it was?
I could read it better when you shrunk it, but
Let's see. Is that okay?
looks
Okay.
good. So I saw this in the Diabetes Forecast magazine, which I get to my house and I really like because I think that it has just some neat concepts and evolving like new technology and day-to-day stuff about diabetes. And so you can find this online, or if you have the magazine in your own waiting room, but it's just how to enjoy Halloween with a lot of candy. And if you're taking care of patients with diabetes, or especially like children with diabetes, just some tips to help. So the first tip is to set expectations. So before celebrating your Halloween, try to sit down and plan it out with your family or your kids. There's a mother that describes having 3 out of 4 of her children with type 1 diabetes. And so she discusses kind of what activities they'll participate in, how they're going to manage their diabetes, what they're going to do with the candy or the treats they collect, and then being open about things that could happen to them, some of their concerns that may happen. One of the examples that she does give in the article later is, sometimes with trick-or-treating, kids may have hypoglycemia or adult patients walking their children around through Halloween may get more exercise than they're used to getting, so they may have hypoglycemia actually while walking doing the trick-or-treating. And so there's a couple tips in here on how to plan for that sort of thing. So being prepared on Halloween night, you want to make sure that you eat a regular meal during the day and try to avoid snacking on high sugary things before trick-or-treating itself, because that could make you overeat later on when you do have your candy if you're kind of not eating your regular meal or you're doing your regular schedule throughout the day. I don't know how to go down, Caitlin. Can you scroll down? Okay, so over to this side. So just trying to eat a regular meal, and then portioning out candy. kids are kids. And so banning them from candy or banning yourself from it's Halloween, you want a piece of candy, is probably not ideal. We are all human. So restricting them may lead them to eat secretively without, setting themselves limits on portion size or dosing their insulin to cover carbs. So that's the last thing that we want to do. And you want to create a plan, create a family. This doesn't sound, I think that this article, it's going left to right, Caitlin? It's not going down?
Right. It's going to the side, left to right.
Okay, so portioning out candy. In this article, they also talk about if you get like a whole bag of Skittles, portioning it out to know what 15 grams of carbs are, and maybe like storing your Skittles and using it at a later time to treat lows is a good idea. They also talk in this article about not using like the high fatty chocolates to treat lows because it may not work as quickly as just the sugary, Skittles would. And so there can be a use to the Halloween candy and just putting it in portions later to treat lows. And there's a really good chart that I have at the end that actually carb counts the most typical candies that people give out, just like small Twixes and small Hershey's, so that you have an idea of the carb counting. And that chart is also online too. We'll get to that in a minute. But basically just having a plan. So, if you talk to your children or even like in your own head, if you're diabetic, okay, these are the candies that I really enjoy. So I will eat, 2 Snickers bars when I come home from Halloween with my kids. And then having a plan to store the candy in a place in your house. Or there's a lot of programs that have what's called a buyback. So you can take your candy to like a local dentist's office and they can use it to give out at their office. So there's a lot of different programs that they have in this article that you can give away like your excess candy to, which I thought was pretty neat. And then there's another neat thing in here too, like offering alternatives. So if your child comes to you with 50 pieces of candy, you can say, okay, well, I'll get you a new like pencil or eraser kit, or I'll get you a non-candy treat for 10 pieces of candy, so that you're kind of making a trade-in for gifts and doing like a trip to the movies or doing something that they may need as opposed to like eating candy. And then also they talk about putting an emphasis on other things that you can do for Halloween besides eating candy. So, doing pumpkins or arts and crafts, or like doing volunteer things like dropping off candy to homeless shelters may be a good idea too. Caitlin, can you scroll to the chart that has there you go. So there should be one more page too. So if you guys look, this is kind of typical carb counting for common candies that people will get on Halloween to help adjust insulin for the candy that they're eating. Do you guys have any questions? Okay. I really recommend, I like the Diabetes Forecast magazine a lot. I don't know what the subscription price is. It's just been coming to my house for years, so I don't know how much it is, but maybe you can even get it for the office and the waiting rooms. I think it has a lot of good stuff in it.
That was great. Thank you so much. I really enjoyed that. I'm sure everybody else did too, but I love the part where they talked about talking to all of your kids, not just the ones with diabetes, about how people shouldn't just eat candy ad nauseum.
Yeah, that is a good point about it. And I didn't want to read it like word for word, but like I said, the mother that had 3 out of 4 children with type 1 diabetes, she says to her children, I'm not limiting you because 3 or 4 of you have type 1 diabetes. I'm limiting you because like a healthy child should not sit down and eat 50 pieces of candy at any given time ever. So, limiting every single child with or without diabetes to eating like 3 to 5 pieces of candy at a sitting so that, they're healthy and it's not restrictive because of the diabetes, but it's restrictive to try to train your child good habits.
Yeah. that was awesome.
Helpful.
Do you guys have any questions? All right, if you don't, I will send everything out after the session. And I'll, of course, send you the reminder for the next one.
Thank
Right.
you very much.
Thank you. Yeah, thank you both for the case and the didactic. That was great.
Okay, thanks a lot.
Bye.